Hello and good day. My name is Teacher JV, and today we're going to talk about your triage. Now, maybe all of you here is already aware with this word or with this term, and most likely you keep on hearing this one whenever you are doing your clinical duties, or somewhat your instructors already introduced to you the concept of triage. Okay, and with that, we'll be starting with its definition. Okay, now if we say triage, it has something to do with this French word called what we call your trier. It means to sort or to choose. Okay. It's the process by which the patients classified according to the type and urgency of their conditions to get the right patient to the right place at the right time with the right care provider. Now, with this definition alone, you already have an optimum understanding of what is triage all about. Okay, so if we're going to trace the history of this one, it actually evolved during the times of war, where sorting of injured soldiers, if they can still return to the battlefield after some medical intervention. And then eventually, it became a process of prioritizing which patients are to be treated first. Okay, so most likely that is our definition and concept with the word triage. Now let's move on here. The next one, basic components of your triage. So we have here what we call an across the room assessment. So it means that you have to widen your horizon, or when you are inside the ED, the emergency department, you will not just focus on the patient you are having an interaction with or someone who is in front of you, but all throughout the emergency department. Okay, the triage nurse must scan the area where patients enter the emergency door, even while interviewing other patients. So it means that you really need to be cautious and you really need to be attentive whenever you are in the emergency department. Whether you're already interviewing or interacting with the client, then suddenly someone entered or an emergency situation came in the emergency department, you need to be aware of this one. Okay, we also have here on the second bullet, it says the triage antenna. So this one should be seeking clues to problems in all the people who enter the triage area. The third one is, if any patient doesn't look right, quickly interrupt any interaction and go investigate. So it's like a matter of prioritization. Even if you are already dealing with a certain client, and then suddenly the next client is having deterioration or emergency case that you really need to attend to, you need to interrupt what you're doing with your former patient and then go and attend to that patient. Okay, so other basic components for triage is the triage history, the triage physical assessment. You already know those things, you've already learned this physical assessment all about, and also your triage decision. Okay, I hope you are doing good so far. Let's move on to the next slide. So we have here the across the room assessment to identify obvious life-threatening condition in general appearance. This one is like we are doing the assessment already, incorporating the subjects, the concept, and also the skills that you've learned from your first year, second year into the clinical setup already. So this one is the ABCDs of life. And here is an update. We are also putting your letter E. Okay, and with regards to letter E, okay, I'm gonna let's change the color of this one. Let's put white. Okay, your letter E here has something to do with your exposure. Okay, Now here, what you're going to assess is the airway, the breathing, the circulation, the disability, or has something to do with the neurologic state of the patient, as well as the letter E, which is your exposure. Okay, so somewhat this is what we call the ABCDE approach. Okay, now why are we going to do this one in the triage, or especially in the ED, in the emergency department? Okay, so this one is like the approach for every patient in a systematic way, just like doing your nursing process, like that you cannot move on to diagnosis, to planning, intervention, and evaluation if you did not do your assessment. Okay, so with this one, we need to go in a systematic way. Okay, and also by performing your ABCDE approach, you can recognize the life-threatening conditions as early as possible. And if you already detect or recognize that life-threatening conditions, you can do critical intervention already. Okay, while fixing that one before you can move on to the other problem. Okay, but if we are dealing with a patient who is stable, this approach is quite easy. Okay, now with this one, let's move on how are we going to actually do your ABCDE assessment. Okay, most likely you've already had an idea or already had concept on how to do this assessment things in terms of our ABCDEs. Now, let's go to the airway. How are we going to assess the airway? So here we're going to look for the abnormal airway sounds, the stridor, the wheezing, the grunting, unusual posture. Example is sniffing position, inability to speak, or maybe they are drooling, or inability to handle secretions. Okay, how are we going to check this one is we're going to talk to the patient. Okay, we're going to have an interaction with the client. That's how are we going to actually check also for the airway. If the patient can actually talk normally, it means that the airway patency of the client is okay. So if the airway patency of the client is clear, then we can now move on to your breathing. Okay. However, if the patient is having difficulty of speaking, somewhat it's kind of gibberish, and you cannot understand the patient, trying to say or trying to utter, you need to further assess that client. Okay, if the patient can talk but not really in a normal state, you need to listen for further abnormal sounds. Okay, if you will do that one, it means that it suggests obstruction in the airway patency of our client. Okay, now it says here that we need to check if there are drooling or inability to handle secretions. Okay, maybe there are fluid in the airway. Okay, we also need to look for foreign body. Okay, if there are swelling around the airway, okay, it means like it's blocking the airway and swelling actually is starting. So you check for the you assess for the swelling assessment. Okay, and also you need to check the mental status of the client during this time. Okay, and we also need to determine if the client can actually swallow saliva or not. If the patient can swallow saliva, it means that there are no blockage in the airway system of our patient. Okay, now let's go back to the assessment if the patient cannot talk at all. Okay, so if the patient cannot talk, you look to see if the chest wall is moving in and out. Okay, and listen for air movement from the mouth to the nose. This is just like, the checking of the airway if you were going to perform your CPR. Okay, now in here, how are we going to manage the airway of our client? Um, if the patient is unconscious and it's not breathing normally, I know somehow that you're also related with this one. Like if we have clients that has no trauma, and we also have clients who has um, trauma suspect or suspected to have a trauma. Okay, how are we going to manage the airway here? If there are no trauma, we will just open the airway using your HTCL. Okay, I know you're already familiar with this one, especially if you've undergone training for your basic life support. So that is your head tilt. Okay, head tilt, chin lift. Okay, so I know you already know how to perform this one, or you can just actually check how to do this one. Okay, so with regards to this, we can if the patient has no trauma at all, you just need to do your head tilt, chin lift maneuver. Okay, and what if you are suspecting that the client has actually a trauma? How are you going to manage the airway of the client? Okay, remember that we really need to maintain the cervical spine of the client, so we need to immobilize the one. Okay, and in immobilizing that one, we are actually using some equipment for that to immobilize the cervical part of our client. Okay, and what are we going to do, or what are we going to use on this part is your jaw thrust maneuver. Okay, so that's how are we going to manage the airway part of our client. Okay, in checking the patient as well in terms of airway, what if the client is experiencing choking? Okay, this one is also being offered to any other um competency office, or maybe competency training centers, how to check for patients who are choking, or maybe at school also someone already taught you how to do this one. Okay, now if the foreign body is actually suspected, you can actually check the mouth or the throat area of the client if there are foreign body, and what you're going to do there is you just need to scoop that one out. Okay, so remove it carefully. Okay, if the patient is able to cough or to make some noise, just encourage the patient to cough so that you can expel out that foreign body that is being obstructed and making the airway patterns of the client very poor. Okay, if the patient is choking or unable to cough or make sound, what we're going to do is, I hope you still remember, with the chest thrust or the abdominal thrust. Okay, so we usually do the abdominal thrust if the patient is actually adult, and we do the chest thrust if the patient is most likely in a late pregnancy, and also of course if it's pediatric, or the patient is baby, we are usually doing your back blows. Okay, and your chest thrust. Usually these are for the infants. Okay, illustrations, you can see this one on internet, or you can just go back and review your books. Okay, so most likely these are our airway management for patients who are experiencing choking. Okay, and what if you are in the hospital setup? You are already in working maybe in the ICU or medical surgical ward, and then you can actually notice this one. If the patient is having difficulty or having problems in terms of airway, how are you going to manage that one? Is you need to suction the airway. Okay, so you already know how to do suctioning, or if not, you can go back and revisit your checklist or maybe your book on how to properly perform suctioning. Okay, and or if that, just encourage the client to to cough up some secretions, or if the patient is already okay, you can actually perform the recovery position. Okay, I hope you still know how to do the recovery position. Okay, it's almost the side lying. One arm is in the face, and then the other one is on the upper side, and the other leg is actually a bit elevated. Okay, now if there are advanced airway management problem of the client, we really need to transfer the patient to capable hospitals. Okay, and that's how are we going to manage the airway part of our client. Okay, now let's move on to the next, which is your breathing. Okay, so what are the things that you're going to assess with this one, or the things that are usual to patients who are having problems in terms of breathing is altered skin signs, cyanosis, dusky skin, tachypnic bradypnea or apnea periods, retractions, use accessory muscles, nasal flaring, grunting, or audible wheezes. Okay, so just like in the airway assessment, you need to look, listen, and feel to see how's the breathing pattern of our client. So we need to assess if the breathing pattern is very fast, if it's very slow, or a bit shallow. Okay, now you can actually just see if there are increased work in terms of breathing. It's because the client is using its accessory muscle. Okay, and then there are chest indrawing or some retraction, and then there are nasal flaring and the abnormal chest wall movement. Okay, and how are you going also to assess the audible wheezes? Of course, with the use of your stethoscope. Okay, so listen for abnormal breath sounds. Okay, and how are we going to continue assess this one? If you still remember in your health assessment how to properly check the breath sounds, is you need to compare the left to the right lung, and then there are patterns. How are you going to do that one as well? Okay, so please go and revisit that subject. And in terms of breathing, also we need to check the oxygen saturation of the client, and we're going to hook the client into your pulse oximeter. And remember, while hooking the patient in the pulse oximeter, there should not be any nail polish, and the normal is like 90 to 100 or 95 to 100 oxygen saturation, and below that one it means the patient is becoming hypoxic. So we need to hook the patient into your nasal cannula for the oxygenation. Okay, breathing management for client. Maybe you've experienced already this one when you're already exposed in the hospital. If unconscious and with abnormal breathing, we usually perform your bug valve mask ventilation. Okay, and this one is actually being attached to your oxygen tank. Okay, and if this one continues, the assessment is still like that one, we are going to follow the CPR protocols. Okay, if not breathing adequately, if the patient is having too shallow or too slow, you just start with the bug bulb mask ventilation with oxygen. Okay, if the oxygen is not available, especially if it's in a primary hospital or in a far-flung area, just go on with the bug bulb mask ventilation. Okay, and then we need to immediately transfer the patient into a capable hospital or center. Okay, and with this one, I hope there are no questions so far. So this is about your airway and then your breathing sound. I'll just clear this one up so that we can move on to the next slide, which is your circulation. Okay. In terms of circulation, what are the things that we're going to assess with this one? Are the altered skin signs, pale, the mottling, flushing, and uncontrolled bleeding. Okay, so most likely with regards to your airway and breathing, we need to look, listen, and feel for the signs of poor perfusion. Okay, so usually with the patients who are having problems in terms of circulation, they have cool and moist extremities. Okay, and if you're going to assess the capillary refill, it is a bit delayed. Remember that if we will perform that one, like 1 to 2 seconds, the color of the nail bed will go back to its normal color once you're going to press that one. Okay, and also here, that is the mottling, capillary refill, flushing, diaphoresis as well, and low blood pressure, especially if there are uncontrolled bleeding, tachypnea, tachycardia. It's because the patient is already compensating with the lost, and sometimes there's going to be absence of pulses. Okay, and in terms of assessing patient who are having problems with circulation, we need to look or assess internal or external signs of bleeding. External signs of bleeding is easy to assess. It's because you will just check the physicality of the client. Maybe you just follow the cephalocaudal assessment or head-to-toe assessment or review of the system assessment, or check physically the chest, the abdomen, or if there are fractures or if there are open wound where blood is gushing out from the client. Okay, how about in terms of your internal bleeding? Maybe there are stomach or intestine bleeding, or maybe any other part of the body. Okay, and with this one, what are the cardinal sign that we are actually checking in terms of your circulation? It is actually the blood pressure. So we're going to check if the blood pressure is dropping. It's because there is an uncontrolled bleeding or whatnot. Okay, now how are we going to manage this one? Okay, for cardiopulmonary arrest, let's just follow the proper CPR protocol. Okay, now if we assess that there are poor perfusion, tissue perfusion of our client, we need to ask the doctor, or we need to check the chart if we can actually give IV fluids. Okay, and if during the assessment you've seen that there is uncontrolled bleeding or external bleeding, we need to apply direct pressure to the client or to the wound part of the client. Remember that blood is a body fluid from the patient. As an infection control, we need to wear our gloves. Okay, or sometimes in controlling this bleeding and the in the direct pressure, the other things that we can do to the client is we can bind or splint the fracture part of the patient. Okay, now how about in terms of the disability or the neurological state of our clients? So most likely you can assess there that there is decrease in the level of consciousness, decrease in the interaction with environment, inability to recognize family members. Maybe there's like a short-term memory loss, unusual irritability, decrease to response to pain or stimuli, and flaccid or hyperactive muscle tone. Maybe the patient is experiencing shaking or seizure or actually convulsion. Okay, so what are the things that you're going to assess in terms of the disability? A while ago, we already talked or tackled about your level of consciousness. And the best tool that we're going to use here is the GCS. So I hope you're already familiar on how to do your GCS, your Glasgow Coma scale. You've learned that one in the health assessment, wherein 15 is the highest that you can actually rate your client. Below that one, the patient is actually starting to deteriorate, and if the GCS of the client is 3, usually it's already in a vegetative state. Okay, we can also use the assessment AVPU. If you're familiar with this one, your AVPU, this one is somewhat familiar with your GCS. Okay, so what is this all about? With this one, we are assessing if the client is awake. We are also going to assess the verbal part of the client, the pain of the client, and if the patient is unconscious. Is the spelling correct? Or if the patient is not unconscious, it should be unresponsive. Okay, so it's somewhat the same or similar to your GCS. Okay, so what we're going to do here in AVPU assessment is the patient is awake. Your verbal is the patient respond to a verbal stimulus if you're talking with the client. In terms of pain, it respond to any pain stimulus. And in terms of that is the patient is unresponsive to stimulus. Okay, so most likely on this kind of assessment, we can check the level of consciousness of our clients. Okay, now here there are times that the patient has the inability to recognize family members, unusual irritability, and sometimes it showcases patient becoming hypoglycemic. Okay, and with this one, if the patient is experiencing hypoglycemia or low blood glucose, maybe we can just do your RBS, your random blood sugar, to check the client's sugar level. Okay, we also need to check the pupils of the client, especially if it's experiencing hyperactive muscle tone or seizure episodes or convulsion or shaking. We need to check that one. Okay, we also need to check the limbs or extremities of our client if it's responding to pain or any stimulus. Okay, and with this one, what is our management in terms of your disability? If there are altered mental status, but there are no trauma that is being detected during your assessment to your client, just place the client in a recovery position, especially if the client just finished having convulsion. Just position the client into the recovery position. Okay, and if the patient is having low blood sugar, of course you need to give glucose or hook to IVF, or if the patient is already conscious, but the GCS is 15 and there are no weakness in terms of of drinking or eating, just offer something that is sweet to the client. Okay, if there are active seizure episodes, we need to refer that one to our client already. Okay, and how about the last one, which is your letter E? Okay, in terms of letter E, okay, maybe I'll just write this one here. This one is the exposure. Okay. If we say exposure, it has something to do with the entire body or the body system is being exposed into something. Okay. It can be exposure to allergens or to biohazards, or maybe we are being bitten by snake or animals, or injury from insect bites and whatnot. Okay, so we really need to assess the client with this one. If we are suspecting that there are like snake bites or animal bites, we need to take a photo of the bite, how do you call this one, of the bite area, or if we were able to trace that the snake, we need to take a photo of it, and then we can actually send that one as a referral to maybe San Lazaro or any hospital that can actually have medicine to this kind of snake. Okay, so with this one, the body will actually start to feel the side effects of this exposure. So maybe there are especially if it's like maybe dog bite, there will be difficulty breathing, there will be fear of water hydrophobia, something like that. So we need to remove constricting clothes and also jewelry, but we still need to cover the patient to prevent hypothermia. Okay, and of course we need to respect the patient's modesty and privacy. Okay, so I hope there are no, or there this part of your assessment, your ABCDE approach is clear, so that we can move on to our next part. Okay, now let's go here. Okay, non-emergency, non-disaster or emergency department triage. Usually this one is already in the hospital part. So the primary objective of an ED triage, usual or disaster are, the first is identify those patients who have the highest degree of compromise for the purpose of providing rapid care to the sickest patients first. So your typical assessment and prioritization of clients. Who are you going to treat first? Okay, or so again, you will go back to proper assessment, considering the ABCs of life, the Maslow's hierarchy. You need to consider those things. Okay, so we need to provide rapid care to the sickest patients first. Okay, now individuals in extremis, even if they are expected to die or require an extraordinary amount of resources for their care, are provided with immediate treatment. Okay, so we need to still perform our responsibilities as healthcare provider, even though we are expecting that the patient is about to die. Next one, we have here the triage categories: the daily triage, incident, disaster, tactical, military, and special condition. You can follow through with this one actually in your book. It's in the page 383. Okay, so in daily triage, this is the everyday routine in the ED department or the emergency department or ER. The goal is to identify the sickest patients in order to assess and provide treatment to them first before providing treatment to others who are less ill. Okay, so it's most likely it's more of prioritizing your patient. And the highest intensity of care is provided to the most seriously ill or injured patients, even if those patients have low probability of survival. Okay, the incident triage occurs when the ED is stressed by a large number of patients but is still able to provide care to all victims, meaning to say that maybe if there are less nurses in the hospital, but the hospital can actually still cater like maybe a mass casualty, additional resources, maybe the on-call nurses or the nurses who are near the hospital, we can still call them, as a backup or, as additional human resource to take care of these patients. Okay. Now let's move on to the next, the disaster triage, employed when local emergency services are overwhelmed to the point that immediate care cannot be provided to everyone who needs it. Okay, so maybe this one is the whole barangay or the whole municipality is already affected. There's like a big number of people who are being affected in terms of disaster. So we need to properly categorize them. So we have the 4 categories here. We have your critical or the emergent, the urgent, the minor or non-urgent, and also your catastrophic or expectant. So we have illustration about this one later on the succeeding slides. Okay, tactical military triage, similar to disaster triage. Most likely, this one is being used in military whenever they are in the battlefield or whatnot. Okay. Special condition triage, it means that used when patients present from incidents such as radiation, biological or chemical contaminants. Okay. And with this one, this is like, if you are being exposed into something, okay, that is hazardous. So this is the difference or the comparison of the military and the disaster. So we have the immediate care, minimal care, delayed care, expectant care. Okay, these are good to read. However, this part is the one that we're going to follow with. Okay, so in terms of the colors, so we have red, yellow, green, and black. So the red is the immediate. It means in terms of acuity, these are the emergent, immediately life or limb threatening conditions, but survival is possible with minimal intervention. Examples are patients who are experiencing cardiopulmonary arrest, severe respiratory distress, major burns, trauma, massive or uncontrolled bleeding. Okay, and the rest here. Please read this part. Okay, in terms of delayed, this one is colored yellow. Treatment of injuries can be delayed for several hours without threat to life. Okay, so these are the patients with compensated physiology but a significant potential for deterioration or mobility if there are long delays before definitive care can be provided. Okay, your minimal is minor injuries whose treatment can be delayed for several days, and this one is colored green. Okay, so examples of this one are, minor lacerations, burns or other soft tissue or orthopedic injury without significant bleeding or neurovascular compromise. So we can actually delay this one for several days or several hours so that we can go to immediate care. Expectant, this is color black, and with this one, these patients are those with no detectable vital signs already, typically identified as victims not breathing on their own. Okay, so this one we can categorize this one as the black. Disaster triage is the primary objective. The disaster triage is the key to successful disaster management is to provide care to those who are in greatest need first, and just as importantly, not provide care to those who have little or no chance of survival. Correct triage is essential to accomplish this goal. That is why you really have to have that clinical reasoning and critical thinking and clinical eye, so that you can actually properly categorize patient and you will know who to prioritize and attend to its needs first. Okay, Now, disaster triage principle, the triage team, triage victim. First victims to arrive are frequently not the most serious injured. It's because the most seriously injured are being treated on site already. Okay, so the victims that are arriving in the hospital or in the ED department, these are the green ones. Okay, the where treatment can actually be delayed. They are just having minor injuries. It's because the black and the red and the yellow ones are still on the field, being attended by the medical doctors or the nurses. Okay, critical patients, fatally injured patients, non-critical patients, and contaminated patients. Okay, in terms of contaminated patients or contaminated personnel, I hope you still remember the hazmat. Okay, here you need to follow through with this one in your book. We actually have here the how do you call this one? We need to follow the proper triage algorithm in terms of this. So we have your simple triage and rapid treatment, or the START system for triaging the adults. This is based on person's ability to respond verbally, if the patient can actually talk or can communicate and ambulate, and per your RPM, or respiration, perfusion, and mental status. Okay, you need to see the figure 22.2. Not that one is the jump start. The This one is the start. We have here 22.3 figure on page 395 of your book, the combined start algorithm. The jumpstart system is for triaging pediatric patients. Okay, start is for adult, jumpstart is for pediatric patients. Start save when the triage process must be over an extended period of time. Okay, so we have here simple triage and rapid treatment. Again, this one is for your adult patient. Critical is red, urgent is yellow, expectant, dead, or dying is the black. So what are the PMR indication? Of course, if the RR is more than 30. If the capillary refill is more than 2 seconds, or it doesn't obey command, if you are asking for its motor response, or to your mental status of the client. Okay, and of course, you know, urgent yellow, and the expectant is black, not breathing, or the patient is having no vital signs at all. Okay, jumpstart system, children has less than 8 years of age, only for disaster or multi-casualty setting. Okay, so you need to properly check the category and the RPM indications here. Start or save is for catastrophic disaster. Especially trained local healthcare providers evaluate patients immediately after the event, but cannot evacuate patients to definitive care. So with regards to becoming a triage nurse, you need to possess these characteristics. You need to have clinically experience. You know, as newbies, we need to expose ourselves with this kind of situations in order for us to gain that experience, that wisdom, that whenever we will be exposed again, we'll already know what to do. Good judgment and leadership as well. Calm and cool under stress. This is sometimes very hard to do and very difficult to perform, especially if you will see blood, patients who are crying for help, shouting for help, body parts being thrown all over the place. It's very difficult to make calm and cool under stress. Being decisive as well, knowledgeable of available resources, not just what is in front of you, but they keep saying that nurses are MacGyvers. We can always utilize available resources, even though we don't have it or it's not available to us, especially here in the Philippines where there are scarcity of supplies. Sense of humor, of course, we should not be very serious all the time. We should always have that sense of humor. Okay. Creative problem solver, available. Being available sometimes is also a difficult task. Okay. Experienced and knowledgeable regarding anticipated casualties. That should be casualties. Okay. So again, it's a very good training ground if you will be deployed in the emergency department of your town, barangay, or in the province. You will learn a lot. You will gain a lot once you are deployed there. You can be actually an EMT to hospitals, or responder to provincial disaster unit of our province. Role of triage nurse is maintain privacy and confidentiality. You are well aware of this one already. Visualize all incoming patients even while interviewing others. We've kind of discussed this one a while ago. Maintain good communication between triage and treatment area. Maintain excellent communication with waiting area. As early as now, or this one should already been developed already in your case, because you're already in 4th years, that you should have that excellent communication skills on how are you actually going to talk to your clients, how are you going to mingle with the client or with your classmates or with your instructors. You should develop and hone this skill. It's because it's fundamental and it's very crucial, especially that we are always dealing with people. So excellent communication skill is very good. Crowd control, we should have that kind of command. Communicate with team leader and seek feedback on decision. We should always be a sponge that we really need to absorb necessary learning that we really need to have. We should be open to criticism and feedback as well. This is what I always embody as a professional right now, that I am always coachable, that you can bend me, you can teach me, you can talk to me, you can tell me where I can improve more. If you embody that characteristic, it's easier for you to work with many people. If you are coachable, it means that they can teach you, they can mold you to become a better person. Okay, now let's move on here. Important key points in triage. The first priority during disaster is the protection of people who are at risk. Okay, we've learned this one already at the beginning of the disaster nursing. The second priority is the protection of critical resources and system on which communities depend on. Okay. If in doubt about a category, choose the higher acuity to avoid under triaging a patient. Okay. And when establishing priorities, registered nurses should be able to make decisions within 5 minutes. Calm and collected, and we should be decisive. Reassess the patient within 1 to 2 hours of initial triage and continue to reassess on regular basis. Patients with no signs of severe illness may develop such during long waits. That is why if we're going to categorize the green patients or the non-emergency patient, we need to go back to them to reassess, or maybe if they are having disease process or developing trauma or whatnot, we need to go back to them immediately as well if we have finished catering the red and the yellow ones. Patients who appear intoxicated actually may have life-threatening problems such as your DKA and should not be permitted to keep it off in the waiting room. Patients should wait no longer 5 minutes for triage. Important key points again: clients are classified based on the principle that intervention must benefit the largest number. Okay, so we need to keep in mind that um, the higher or the larger the number that can benefit to this one is we need to follow that one. Okay, if in major disasters, those requiring minimal care to save their lives are treated first. In an emergency, clients with with the greatest risk receive the priority. Important key points in triage: consider the age of the client. If it's too young, if it's too old, or if the client can actually ambulate or perform or can walk, we consider the age. Fragile clients as priority, below 12 months and above 60 years old. So pediatric and adult clients. For clients with multiple complaints, address each client concern one by one. Okay, life-threatening. Consider symptoms like chest pain as your priority. Maybe the chest pain is actually a start point for the patient. Will have an elevated blood pressure, or there's like an occlusion, or maybe a pathognomonic sign um, for stroke or any other CVA disease. Okay. Symptoms that suggest poor outcome, like profuse bleeding, should be considered a priority as well. And think the ABCDE technique or approach to the client: airway, breathing, circulation, disability, and exposure, in which we've already tackled earlier in this discussion. Okay, so this is the triage tag. You can just check this one out. I think this one also is in your book, if I'm not mistaken. And okay, that's it for our discussion in terms of triage. I hope that you've learned or you've gained something. You've learned something about this discussion, and it's about time for you to, to properly incorporate the theory that you're having in your online classes now that you are already being exposed again to the hospital. So, it will take a while to go back to the groove of having your duty in the hospital, but I hope and I pray that you know it will go back the soonest, so that you can finish all your cases, you gain more experience, more exposure to the clinical experience that you really need to have, so that once you take your board exams and you go to your duty, once you become registered nurses, it's a smooth transaction and it's easy transition as well. And with that, I want to say thank you, and I'll see you again next time. Goodbye.